All right.
There you go.
Wow, amazing. Okay, well, appreciate the opportunity to talk a little bit about contouring. I hope you find this useful. This is going to be heavily slanted toward MR. I think most people are migrating towards MR planning, and I think hopefully this will convince those who are not that it's well worth the juncture. But it's the ironic fact is in 2005, I handed out 1,000 versions of Prostadoodle at Astro, 2005. And I thought people would take a look at that. And the whole world in about a year or two would be doing MR planning because it was so spectacular. And as it turned out, it was about 10 years later that everyone started using it. But interestingly, that Prostadoodle still gets 500 hits a month. So the whole world is kind of catching up and still using that. And so key of all contouring keys, though, is MR anatomy. If you know MR anatomy, you can recognize elements on ultrasound. And I have to say, ultrasound is a spectacular second. It's very close second. I would never have said that a few years ago, but as I've really put this together, CT is a distant second. It's a gray blur. A lot of things blur together. But the challenge of MR for anyone is confounding clarity instead of confounding lack of clarity. And that is you'll see things and you actually don't know what you're looking at, which was my life for about 10 or 15 years. I used to pull these images, send them around to urologists, radiologists. What is this? Kind of really naive stuff. But gradually we were able to piece together what's happening. And variation is, of course, the most confounding of all, because just when you get this sort of classic picture of this is the GU diaphragm, it gets blown up by variance. And so you have to be kind of ready to adapt to the individual case, which is, N=1 medicine. We're kind of learning all about individualized medicine, and this is really in the same wheelhouse. But the anatomies, really prostate anatomy, functional anatomy. So on CT, prostate blends with adjacent functional anatomy. Dose escalating functional anatomy is a formula for disaster. I'll get to that later. We don't want to dose escalate, things that are not prostate or prostate cancer. Then there's tumor anatomy. This is kind of the last 5 years. This really pushed it so that I think people really feel like they need to do MR to see the tumor. We've never actually seen the tumor. And then dynamic anatomy, as I'll just allude to later. So this is the image from the Lancet paper on functional anatomy. And I think this shows all the functions, sexual, bladder, bowel, streaming through and adjacent to the prostate. So it's quite an incredible engineering feat. And I think I always argue this makes prostate cancer treatment the most daunting challenge in radiation therapy, because somehow we have to preserve as much of this function as we can. Now, the last 5 years, we're getting tumor. And of course, you add tumor to the mix of all this functional anatomy, and it really challenges sort of everything we think about. For years, we've thought about dose escalating the entire prostate. I'm sure most of you do that. But what's happening, I think, in the weeds still is that people are moving to dose shift, where they're getting more dose to the tumor location, sometimes much more dose, and then even backing off certain parts of the prostate that don't have tumor risk. So apex, believe it or not, all I will cover today is the apex. I know Bob is really disappointed because Bob did, it's really the high point of his career, a classification of the base changes. And he, again, it's been a drop down since there, but I'll cover that on part 2. The apex, though, is ground zero. There's no question if you wanted to improve your performance and your patient's outcomes, you would just get better and better and better at the apex. And believe it or not, I am still trying to get better at the apex, but it is the ultimate convergence of both tumor risk and functional anatomy. There's a lot at stake. Tumor risk, because it's pure peripheral zone. GU, an external sphincter within and below. So you've got tumor risk and a functioning sphincter in the same space. Sexual function, neurovascular bundle terminates and sends microscopic nerves, cavernosal nerves, through the GU diaphragm. From there, you can't see them. They were only found on cadaver studies, but they may well be a critical target, according to Johns Hopkins that is the critical target. Still being worked out, but rectum is held closest to the apex by the rectourethralis muscle. So some of these things may not be as familiar to you, but these are going to be the 4 things I'm going to try to hammer in the talk. The PZ-TZ distinction that's so clear on MR, but not at all clear on CT. External sphincter, which is not really external, it's external and internal. The geodiaphragm recognition, the layers of the geodiaphragm, so you can kind of spot this and know when you're overestimating the prostate. And then the rectourethralis, that's really a new kid on the block, not familiar to many, but I'll try to make it clear. So first, for the tumor risk part, the prostate on MR, you can see very clearly the transition zone, this dark area, which is pure transition zone, low tumor risk, and the peripheral zone, which is white. And again, Adam Bliss, one of the residents, said, wow, it's like it's a different organ altogether. But you notice the peripheral zone comes around like a rind, but at the apex, it's pure peripheral zone. That's why I say apex is ground zero. So I contoured a patient this week, contoured the transition zone, contoured the peripheral zone, and you can see the peripheral zone comes down like a rind around the transition zone in this patient, but then you have this boot, and the apex is pure peripheral zone. That is critical because 85% of tumors form in the peripheral zone. If you were going to somehow boost this risk area, then you would kind of back off on transition zone and hit the apex and the peripheral zone. But again, that apex is tricky because the so-called external sphincter comes up into the apex, up to the verumontanum, which is a structure you can see, but it's up to the transition zone. And then it comes down from the prostate apex down to the penile bulb. So this is the trouble right here. That's the challenge. Again, I'm going to have a gold star. I want you to remember that it's within the apex. Then this is a throwback to one of the most famous functional anatomy papers in the urology literature. It's all the way back to 2002, Coakley, very famous radiologist. And this is a coronal view. And what you first want to notice is how clear the apex is on coronal view. It's actually spectacular. Anyone, man in the street, could look at this and tell you where the apex is. And what Coakley did is measured the external sphincter, and you can see it coming from the apex down to the penile bulb. And he said if that's over 1 centimeter, then there's very low risk of incontinence with surgery, which is an amazing index to have because, you know, in our consultations, many of these guys may want surgery, but they're terrified more even than impotence of incontinence. And so having this to be able to provide this information is useful. But what they didn't see or notice at all is the fact that that sphincter extends well into the prostate. So a whole bunch of humorous emails ensued. Some pretty snooty urologists I ran into, you know, we call it the external sphincter bill because it's external to the prostate. Like emphatically clear, no, that's not. But as it turned out, we had all this on Prostadoodle, and then about 5 years later, there were three papers in urology where they actually did sectioning through the apex and proved that the sphincter extends inside. But you can see you've got to boost this. You've got a head start on a stricture in every patient because you're boosting a functioning sphincter. So if you overestimate this to any degree, you know, you're playing with fire. The other part about the external sphincter, which is the most amazing probably variation, is the length variation, and it's extreme. So over to the right here, you see a 0.5 centimeter external sphincter, and over here you see a 3.2 centimeter. That's our longest, but this is an astounding difference. And again, you're not going to want to overestimate this, but if you had to start, I would say everyone, if you're going to start before you contour anything, look at the sagittal MR and you'll see this remarkably clear picture of that external sphincter coming down. You'll see the prostate. It's kind of a lollipop. This is more of a lollipop configuration. This one is 0.5 centimeter, no external sphincter at all. And so if you used one of those old rules, like it's 1.5 centimeters above the penile bulb, you would be here and you would be wrong and you'd be missing prostate. If you used it here, you'd be grossly overestimating the prostate. And honestly, if any of you contoured this case on CT, all of this is a gray blur. You would not stop here. So it's critical because of that sphincter. And then this is just what the sphincter looks like within the prostate. This is down in the prostate. This is just the upper GU diaphragm. You still have some prostate tissue here, deeper in the prostate or the external sphincter. But notice you could contour. Who could blame anyone for contouring all this? It's round, it's big, round stuff going all the way from the prostate, and it can go down for centimeters. So who could blame you? You can't blame me. I used to do it all the time. There was a famous lecture given by a Harvard physician, and he says, I teach all of my residents to contour the prostate down to the penile valve. And I mean, he said it with pride. And it was like, at that point, I already knew, oh my God, this is Harvard. We're Harvard of the East. No, anyway, it was quite a shocker, but that's kind of the way people use it. So GU diaphragm, you have to kind of know what you're looking at here, and then you can make sense of it. But remember, this is someone with a fully developed layer by layer GU diaphragm. And that one with a 0.5 centimeter, you're not going to see all these layers. They don't have it. So this is the concave muscle. You look at the musculature for context. There's concave, then you get flat, and then you get what's hourglass or headphones, kind of convex here when you're in the upper GU diaphragm in green. And then you finally reach the external sphincter out ahead of. So these come back. I call this the gold medal pose. You can see it very easily. Here's the head. Here's the arms going up, holding the gold medal above the head. Once you're here, and especially if you see the rectourethralis muscle here as a triangle or as a little, then you're way, way down in the GU diaphragm. And you should say, wow, that's can't possibly be prostate, even though at all of these intermediate levels, you can still have what we call a nubbin of prostate tissue. So this is how it looks. This is a classic case where you see prostate. No one would doubt this is prostate, but then you start to get these convex muscles closing in on the sphincter, even more clear here. This is sort of hourglass headphones. But look at this, you would be tempted to contour all this as prostate. Just say, oh, those are the two lobes coming out. That's what we treat on exam. But look, it's here and it's here, and it's not prostate. The GU diaphragm is a substantial structure with light, surrounded by light, soft tissue, and you have to know that that's not prostate. You're getting centimeters below. But this is the medal pose. You see this muscle back, and now you've got the gold medal sphincter out ahead. And interestingly, if you're doing brachytherapy, this is really key that, and I'm working on an atlas now of this because this is something that's not covered well, but this is the ultrasound prostate apex. And then you see here, you don't see this one as well, but here's the headphones sphincter. Again, who could blame you for contouring this as prostate? But you can see it looks nothing like prostate tissue. Now this is the gold medal pose with the sphincter out in front. So once you see that, you're way beyond. But again, as you will hear, people in very good programs contoured this, bombed the hell out of it with seeds, and kind of patients paid a price for it. So it's a big premium on defining that. Rectourethralis is probably a muscle thing you've never even thought about, but here is the rectum in yellow coming down, and the rectum has this bend. So this is the anal canal surrounded by big, heavy sphincters that give continence. And then this is a unique sling almost. It runs in parallel with the rectum and inserts on the rectum, and it holds the prostate, that bend in the prostate. So it's almost like an upper sphincter effect because you've got this bend in the road, and it inserts on the perineal body, but the insertion is highly variable. And again, this is key when we're doing spacer. You have to know this anatomy really well to understand where you want the spacer to go, which is why I include it. But it's important to understand this because it's kind of hiding in plain sight. Now, this is funny. This MR, I always look for kind of classics. And like 2 weeks ago, I found this MR that makes a point that I've never been able to make with an MR. So if we look, here's the prostate, here's this thickened rectum, this is the rectourethralis, kind of completely embedded in the rectal wall, right? It's thin here coming around. You see this thick, and that gets thicker as you go. But what's most amazing about this just example is here's the rectal urethralis. It's 0.5 centimeters thick. It's almost that thick up here if you count the whole thing. So you've got this natural spacer protection built into many patients' bodies. Now, this is a thick, that's a thick rectal urethralis. I always call it like a bad wig, but you can clearly see the rectum is completely separate from this. Believe it or not, we traveled to Toronto to look at MRs done with a probe in place. And I mean, it was like, eureka, we found it. We could see that these two are separate. You can see it a mile away on ultrasound in the OR, but it's like it was a mystery. And so here again, you see very clearly this is its own thing, and then it merges with those anal canal sphincters. So again, that's important to know that's there, though, especially in those that have a super thick. I mean, you could almost look at those and say they don't need spacer, right? There, you have lots of room there. And then this is just that same case from earlier, but it shows you how this rectal urethralis comes up. You see this thickening, bad wig, and then this little stem going up. This can be a stem or a triangle. And once you're there, you're really at the very bottom of the GU diaphragm, and you're done. You know, you're done with, if you see this, there's no prostate there. So it helps you limit that. Now, how did this come up? I just want a brief aside. This is, it's all about the Bermuda Triangle, which is a kind of a famous term for this horrifying thing that can happen when you do seeds. This is a seed implant. Right at the end of the case, you see this nice row of seeds, perfectly spaced, well within the prostate. This is a CT scan an hour after, and you see the rectum, and you see this cluster of seeds coalescing right on the rectal wall. And virtually every brachytherapist who does seeds has had this moment, like, I know I didn't put those seeds near the rectum. So how does this happen? Well, this turned out to be really tough to figure out, but here we are back again, recto-anal flexure. The rectal urethralis is in pink. It should be in a different spot, but you get the idea. It's holding this angle. And then when you put a probe in, you stretch that out a lot. You can see it. This is the hump you have to get over with spacer. But if you then put in seeds in that angle, those seeds look beautiful, which is what we saw. But you take the probe out and this recoils back. Now the rectum is sitting right on the prostate in its native state. And that's how you get that Bermuda Triangle effect. But that helped us. That gave us, figuring this out gave us a big heads up on doing spacer, because a lot of this anatomy comes into play. So I'm just going to show you an image of how this works. I hope I can show you. Let's see, maybe I got to do it over here. So a nice animation. Yeah, so the probe comes in, straightens out that bend, and then now I'm going to have the probe drop. And when you drop the probe, if you're doing HDR, this is gold, right? Because this is the rectum in orange. You are now 0.8 centimeters below the prostate. You can, that's a mile in brachytherapy terms. So if you just drop this, now the apex is different. But the real key is that when you drop the probe, the prostate changes shape, rounds up, shortens, and it is now the shape of an MR natural prostate. So if you're one that wants to fuse an MR, this is a way to get this. So even before you contour in the OR, you have to explore these dynamics and say, okay, if I want this to look like the MR, then I have to drop the probe. For HDR, it's fantastic. But then again, everything, you take it out and the probe's going to drop, you're going to squeeze, and everything's going to recoil back to the original. And so very useful to know that, though, because this is an incredible probe dropped position, is an incredible view, but it also shows you that as you drop the probe, you create this hump that's critical for spacer placement. And so let me try. And then this just shows you an actual case. This is a close probe, kind of squeezed. Liz Jaworski, one of our residents, did this project. It's incredible. You drop the probe and now you get a completely different shape, but this fits like hand in glove with an MR. And you'd never know these are even the same. And as you go into the OR, you might naturally be inclined to do a close probe and change it. But whatever you do, the minute you take out the probe, you're going to go back to this shape. So it pays to go a little bit closer on this before you contour anything. So why is proper apex definition so critical? Why do I say start there, spend a month or two going crazy with all of this anatomy and these structures? Ascend had an unacceptable level of GU toxicity due to seed deposition within the GU diaphragm all the way to the penile bulb. So this is a key randomized trial. What would we think about Ascend, which it's going to end up with a 30% difference in BNED at 15 years if GU complications were in a normal range? It would be a very, very different story. And it is shocking the complications were not 50 to 100%. I went out with Juanita Crook and we went to Vancouver, and when they were reviewing these cases. And I mean, honestly, they should have had 100% GU complications. The entire GU diaphragm, all the way down inside and beyond, well into the penile bulb, was bombed. And so I take it that these functions are very resilient, but they were just lucky they're so resilient. It could have been kind of end of the world disaster. So although prostate cancer specific mortality may not differ with Ascend, 30% difference in ADT and salvage will be decisive. When they publish the 15-year results, there won't be a survival difference. There won't be a prostate cancer specific survival difference, but there'll be a 30% difference in guys ending their lives on ADT, and that's a quality of life infraction that's unnecessary, can be avoided. So HDR series in Australia had a stricture rate of 40%. Again, this is technical failure, but it just shows you if you don't mind your P's and Q's and don't understand that apex and you pull any dose below the apex, there's a real incredibly important consequence. Tumor anatomy, I'm just going to do this a little differently. I would say go to the ACR website. It's spectacular. It's every variant, every PI-RADS, all the classification. We just don't have the time for that today. But I think if you do multiparametric and start seeing tumor, you will never go back. So T2 and ADC are now the key sequences. These are often lateralized. So even when you have 12 out of 12 cores positive and you'd think the whole thing, very uncommon to see really gross, terrible disease throughout. Usually one side takes off much more than the other side. DRE will kind of tell you that. But full thickness spacor is game changing for tumor boost. So the FLAME trial was doing tumor boosts and it looked very promising, but you actually look at the dosimetry on that trial. So if you're going to say, I'm going to circle this tumor, I'm going to boost it, none of those tumors actually got full dose boost. It was all compromised by the rectum. On the other hand, what we found when we tested this, when you had full thickness spacor, you can give full dose to the whole PTV way before the rectum. So if we look at this, I'll just go through a couple case studies to give the flavor of this. 51 favorable risk teacher, science teacher, read everything, favoring active surveillance for a 3+4 low risk. And his MR, though, kind of a shocker, right? This is a T2 sequence, has this big anterior T3 that I'm pretty sure was never even biopsied in his original go, but he is not someone with this who's going to want to watch and wait. This is the ADC map, the dark, showing the dark tumor. And then this is a coronal, and you can see how substantial this tumor is and the location. I use this image to convince the surgeon not to operate because, again, 51-year-old favorable intermediate risk. There's no surgeon that isn't really advocating surgery as the first choice. But this was a very bad tumor you would never know was there, and you probably would undertreat if you did treat. So he had ADT. ADT, you'll see, just it shrinks these tumors with ECE down to nothing, and then he had combination. He's many, many years out, doing great. 55, unfavorable intermediate risk, possibly T3 by exam. This is a guy who really had, this is not a possible T3 on MR. It was subtle on exam on DRE, but I think this is very clearly outside the prostate by a kind of a mile. And this is a little bit of a sad story, but his tumor engulfed, look at the neurovascular bundle on this side, clear, it's completely engulfed on this side. And so he's got T3 disease. It's not surgical, but again, he saw one too many radiation oncologists. I told him he needs combination for this. Saw another who said, oh, combination is so toxic, you shouldn't do it. And he got really miffed at the difference in opinion, then went to a surgeon. And you know, surgeons have a way of selling young men on an aggressive approach. So he came back to me. I said, I wouldn't treat this with surgery, but you're going to need radiation for sure afterwards. But if you want to, I can tell you this, your sphincter is 2 centimeters. He was very worried, really very worried about incontinence. He looks like the cover of a veranda. He's like what I call a veranda person. They're a veranda couple. They belong on the cover of House Beautiful, like sitting on a back porch, drinking fancy drinks. He was like 55, but looked 40, his wife the same. They were really buffed. So I said, hey, and so they went ahead and they ended up on a Mohs protocol where they did margin control. And this is so sad. When he came back, they basically kept resecting, and you can see that long sphincter. They basically carved and excavated the whole thing. And he had complete incontinence, like penile clamp incontinence. You can see it here. Here's the sphincter. So I say this just because there's such consequence to the functional anatomy around the prostate. This was just terribly sad. And he was, kind of furious at me. Why didn't you tell me this could happen? And I never anticipated this kind of thing. And then finally, he had positive margins post-op RT. He had distant nodal recurrence year 4, still out there, kind of more or less under control. But then we have a 55 high risk, Gleason 8, true high risk, 6 out of 6 cores on one side, PSA 32. So way, way, way over the line. Very impressive exam. But I never imagined this. Look at this MR. He's got tumor growing out of the prostate, growing all the way through the pelvic musculature. This is like T4.5, and you would never know. Honestly, on CT, I should bring the CT because, again, this is all a gray blur. This is all blends together. But here's the real kind of good news. This is 4 months after ADT. So if anyone doubts, you can doubt whatever you want about the mechanism of ADT and its help for radiation. I don't have any doubt that this local effect is so life-changing for these guys. This is all back inside the gland. We kind of gave him a combination, and he's a good ways out. So then this is just showing you SpaceOAR, good SpaceOAR, I think. I put the paper in. We're about 2 techniques beyond what's in that paper, but if you can get SpaceOAR like this, and at the base, mid, and apex, one of our residents, Alex Bryant, is famous for the Bryant maneuver, where we dissect this to get that all the way down. If you look at SpaceOAR in general, the apex, it's hard to get dose down there, but he actually is famous, world famous, in a way he never will be in another realm. But in any event, so my summary for this is, never a more exciting time to treat prostate cancer. Accurate contouring of prostate, functional anatomy, and tumor creates opportunity for total success, what I call total modern success cure with full function preservation. So again, remember, 2/3 of the vessel-sparing patients were combination. So we had fantastic sexual function preservation in patients that are notorious. They got hammered, but we didn't hammer the things that mattered, and they still got very, very, very high dose to the prostate and the bad tumors. But function preservation is not quality of life. This goes back 30 years to guys who were totally incontinent after surgery, but their quality of life was fine because they'd say, hey, that's the price I got to pay. I knew that was coming. I'm a man. I can take it. I don't care if their quality of life, their bother with their incontinence was almost zero. They should have been. Now, very hard to find guys like that now, But, preservation means that 5 years after treatment, you cannot tell if you were ever treated. So, for example, now our post-IIEF is within 2 points on a 25-point scale in 50% of our patients. That's preservation, full preservation. Now, 80% have some acceptable function below baseline, but this is really, when you look at that grid and you look at that tumor and you look at that functional anatomy, if we can migrate a little bit to heavy tumor, sparing of as much functional anatomy as we can, I think you really can hit preservation even in bad tumors, probably in 50%. Kind of already there in GU, about 85% for that. And rectum with SpaceOAR should be 90 or 95%. You're just not getting dose that's going to affect their function. And that typically has not been true. But tumor definition limits necessity for whole prostate dose escalation. This is going to be worked out. I'll be dead and gone by the time this gets worked out, but it's so exciting that you can actually see the tumor, you can shift dose, and it's going to allow even better cure and preservation. Focal and selective cases might improve things as well, but I don't know if, I'm not a focal guy. I don't feel comfortable with that. Talked to a radiation oncologist from Sloan Kettering though, and she was going crazy because the urologists were doing focal for everything. Appropriate or not, everything they saw, they would either do cryo and it was focal cryo. And of course, even full prostate cryo has no chance in most tumors. So it almost didn't matter, throw something at it, go focal. And yet I think we could do it really well. And then anatomy unlocks new opportunities. This, what we've called gel-enabled dose escalation project by our resident, Jamie did a fantastic project looking at how you can actually give brachydoses with external beam if you get a thick gel, and thick gel really is about 0.5 to 0.6. It doesn't have to be 1 centimeter. When I ask, if there's any questions, I don't have the time. I probably burned through quite a bit. Yeah, I'm already over. So I guess we can hold questions, or if there's any questions, people can email me.
Bill, I just wanted to thank you for, we might have time for a question or two, but thanks for sharing your decades of expertise. So, clearly MROC has goals of standardization, both of outcomes, standardization of collection of data, which is important, but I think we all agree that we want to be doing something different 5, 10, 15 years ago than we're doing now. And I think your talk sort of brings forward that there's as much to learn in the future as has been learned in the past. So thank you for bringing that perspective.
Yeah, great. Appreciate it.
Any burning questions for Bill that could be shortly answered in the couple minutes that we're over? How long do you think it takes to get the hang of spacer placement with the rectal urethralis, Bill? Is that something that's done in 5 cases, in 50 cases?
Well, I think it depends on the case. It's really that the way that rectal urethralis comes up into below. I mean, there are some cases that it's almost impossible to get the apex covered. And they're the same ones with that super thick rectal urethralis. So they may get benefit from that. If you want to see what I think will be the solution, I can play this video. I do these now with the urologist, and what we did, I'll show you what I think is kind of guaranteed to work, but it's a little not sure. If you use a penile clamp, which is a really commonly used device, you can see this clamp, it's a rigid thing going in. We can't put those in, the urologist has to put those in, but you can move and lift the prostate. So what we're trying to do is create a space by dragging down. This shows him lifting it up, and then we do this water dissection. Now, why this is important, and then we do this Miller-Tiller, one of our residents created this Miller-Tiller move where you just rotate as you're coming out, and you end up with this massive, but again, you see that probe, this is for big glands. I would say there's 2 things. Some glands, the Apex is tough. I think you can learn how to do it well in less than 10 cases. But I also think this, for big glands, it's very tough to get that, to lift the gland literally. And so this, I think what we're going to start doing is, you'd need a urologist for this, but that's okay. This is a really big deal. If you get this kind of spacing for a huge gland, that's going to be a game changer. But for standard cases with moderate size, less than 50 cc's, but I do think the quality thing, we've filmed these, we've learned tons by filming, and you can get a good recorder for $1,500, review these. And I know Dave Heimberger is a good resource on this, because Dave actually took this back from urologists. He does it. I think, is that still true, Dave?
Oh yeah. Yeah. We're doing, probably 10 a month.
Yeah. And that's us too. But I think, what would you say? What would your answer be if you have reasonable technique, and you could probably get the hang of this in probably between 5 and 10, I think. It's just,
yeah, probably minimum of 10, I would guess. I mean, because as you said, you just have a lot of anatomic variation, and we had the benefit of doing this after doing 500 to 1,000 seed implants too. So it's the ultrasound skills that probably take the longest to acquire. So more so than the needle placement necessarily, but
you do it in the OR too, right?
yes. Yeah.
That's
we tried to do outpatient, but just with local anesthetic, and you just can't get the quality of spacer placement, just patient motion, patient comfort. It doesn't work very well, and we just had no real pushback doing these with either conscious sedation or short general anesthetic.
Yeah, I don't know if that answers your question, Bob, but it's actually, I think the water dissection is a big deal for us. We found that was a major game changer, but I'm also backing off on that a little bit. So I don't think it's insurmountable. And I think, you're lucky you have an ultrasound unit in the department. You could really do this very well. Residents, I have residents place the gel, which is so unusual. I talked to Krause at Beaumont. He says, you don't let residents do spacer, do you? And it's like a year and a half ago, I said, no, never. I'd never do that. But actually, what's so interesting is each resident has a take on all of these things. Each resident, like the way, if you say, okay, put that in now, like this Miller Tiller, where we rotate as we're coming out, and it lifts the prostate and creates this huge thickness. That's, that came about partly because residents are looking at it, thinking they're all smart, and they get it. So I think it'd be a great plus for the program if we did this at the main as well. But I also think for these big glands, you got urology involved. They can put that clamp in 2 seconds. That's a very common thing for them, and that solves the insolvable, the huge gland. That I think, Dave, don't you kind of agree? Those are the toughest. You end up with a little splurge up at the base and mid, but nothing at the apex. And this, yep. So I think there's, but I also do think that there's strong evidence that dose escalation is critical to outcomes in these bad tumors. And I mean, it's kind of astounding what this getting the rectum out of the way lets you do dose-wise. It is absolutely, I think it's game changer. I mean, it's ironic. I'm going to end my career by proving that you don't need to do brachytherapy, just need to do good gel. But, it'll take a few to prove that, but it's really, really exciting.
I guess thanks again. It being 10 past the hour, we can stop. And part of the heart of my question was specific, but also general, is I think we should, with these education sessions, I'd like for them to be translatable into clinic and translatable into our MROC sites. And, I don't want these to stop here. I'd like to see some implementation, and to the extent that there's requests for follow-up data or follow-up lectures, please share with the group so we can continue this momentum going.
Yeah, and I'd be glad to have people out, to see this and see how we do it. And but not as a, this is the way to do it. I'm a continuous evolution. Like this clamp, I think this clamp was the latest idea I had, but it's like that looks like the ultimate. But again, if you talk to me in 6 months, you know, we always find little wrinkles, and so in that sense, so people are welcome to come out and see how I do it. Dave's done a ton as well, so I think it's you know, it would be good. But I think filming this stuff, filming your cases is really good, because I can show you the bad ones, the impossible ones with that. We all like this, very proud. Get the star on your forehead like grade school. But you know, the ones that are not pretty are the ones that are more important. That's the ones you really learn from. So thanks again.
All right, thanks all. Take care.
Yeah, thanks, Bill.
More than welcome.